Well, I think one of the things that we like to do is to rebiopsy the patients. I always advise people when I talk about this to try and get the patients rebiopsy at the time of their first recurrence. We already talked about what's done in the adjuvant setting. There aren't as many patients, very happily, that recur now because of the effectiveness of the adjuvant treatment, and many studies, including some at this meeting, have shown that. So there are fewer patients that recur, but there's still problems that we have with those patients, and then generally speaking, they're not curable. It's always a good idea to rebiopsy the patient at the time of the first relapse to be sure that they are in the same, showing the same expression of markers as they were before, that they're still HER2 amplified. And then if they are, we have a number of choices. They can receive trastuzumab or Herceptin plus chemotherapy. They can receive these antibody drug conjugates. Again, there'll be several new ones out. There's also one TKI that's on the market right now, lapatinib. There's another one. There was very interesting data presented at this meeting on another TKI, tucatinib, which looks very, very interesting and seems to have excellent brain penetration. That brings up the point that one of the major problems we still have in the HER2 positive metastatic setting is the prevalence of CNS or brain metastasis. They seem to occur more frequently than in other sorts of breast cancer patients. And obviously many of our large molecules, including the antibody drug conjugates, don't seem to cross especially well into the brain, although sometimes the blood-brain barrier can break down as patients are treated, and so you may get some more of it in. But that's been a continuing need, and some of the newer agents coming out, I think, will be very good for that.